All right, here we go. Hello, and welcome to the Roseman Roadrunner Resource Series. I'm Brenda Griego, Roseman's Alumni Director, and in just a bit, we'll be hearing from Dr. Ken Kumke and Dr. Dustin Christensen-Grant. We're going to share some exciting thoughts about how you can advocate to change how pharmacists impact patients' lives. But before I introduce them, I have two quick housekeeping items. First, this presentation is being recorded and it will be posted on Roseman's YouTube channel next week. We'll email you that YouTube link when it's available, along with a PDF of tonight's slides. Second, following tonight's 45-minute presentation, there will be a 15-minute question and answer period. To submit a question, please click the Q&A icon at the bottom right of your screen. Drs. Kunke and Christensen-Grant will respond to your questions in the order they were submitted. And now it's my pleasure to introduce our speakers. Dr. Ken Kumke has been practicing pharmacy since 2003 and served in management positions for most of his career. Roseman was delighted when he became a faculty member several years ago, and also when he began serving as the executive secretary for the new Nevada Pharmacy Alliance. He has a passion for advancing the practice of pharmacy in Nevada. Our second presenter, Dr. Dustin Christensen-Grant, joined Roseman and the Utah Society of Health System Pharmacists in 2014. He's remained involved in advocating for the profession through his work with USHP and the Planning Committee for the annual Utah Pharmacy Day at the Capitol. Our speakers tonight are committed to their profession and their patients, and we look forward to hearing their words of wisdom. And now, take it away, Dr. Christensen-Grant.
Thank you, Brenda. Really appreciate that introduction. And we're super excited to be here tonight with alumni, current students, whoever may be watching now or in the future. We're just really excited to talk to you about the pharmacist, advocating as a pharmacist, the future of advocating as a pharmacist. And being two academicians here, we're here because we have a passion for it. We're here because we love our profession and we want to see it moving forward. But if anything, we want to really get everyone feeling today is that as an academician, we love this, but it really comes down to our alumni on that front line that carry that voice that really is going to empower the future of pharmacy. So we are really excited to talk with you today. Here's who you're going to be seeing or hearing from today. And I want to kick things off by sharing with you how I got involved in advocacy and kind of my path getting involved in advocacy. So it started for me when I was in pharmacy school at Wingate University. At Wingate, I was involved in a number of organizations, including NCAP, which was the North Carolina Association of Pharmacists. And they had a pharmacy day on Capitol Hill. And I had the pleasure of being involved. And really it was student involvement. I was there to present on a particular topic and host kind of a health fair. But in terms of truly advocating, there wasn't a lot that I was doing. And then when I became a faculty member here at Roseman and I started getting involved with our state associations here, USHP and somewhat UPHA, I started to get more passionate for the things I wanted to see in pharmacy. And now my role in admissions has helped that even more as I see young future pharmacists that are hungry to do things that the doctor of pharmacy allows them to do. And they motivate me. They get so excited. And I was like, I've got to do things. I want to do things. I want to see the future of the practicing pharmacist evolve. And because of that, I've gotten involved with USHP, as mentioned, also involved with Pharmacy Day on the Capitol here in Utah. And my vision is that particular day is going to evolve and become less of what it's historically been, which is a student-driven event, and become more of a unifying pharmacy across the state of Utah to move the profession forward, and not just for the sake of it, but for patient care as well. And to tell more about how he got involved in advocacy, I'm going to turn it over to my colleague, Dr. Ken Kumke.
All right, thank you so much, Dr. Christensen-Grant. My journey was a little different. I graduated in 2003, and for the majority of my career, I have worked in a community pharmacy with a little bit of compounding scattered in there. As a community pharmacist, I would go into work and I would do my job and I'd go home and I would collect my paychecks. And my vision was that my employer, other people, other other associations, maybe the Board of Pharmacy. They were all the ones that were advocating for the profession of pharmacy, and it was not up to me. So in November of 2019, I got a job at Roseman University, and my position changed where I was talking to a lot of pharmacists, about 300 pharmacists throughout the state. And as I was talking to these pharmacists, I realized that pharmacists in a whole bunch of different positions were feeling the same way I was when I was at that community pharmacy. They had questions that they wanted answered, but they were trying to get other people to answer those questions for them and not answering them themselves. So questions came up on a regular basis, and I was just like, oh, I know this is a need that we need to start figuring this out. We need to put people together and start bonding together and figure these things out. But right now I'm so busy. So then in March of 2020, I signed up for a medication therapy management training. And in that training, we learned about how to take care of the patients, how to, talk to them about their medications, how to assess them, how to make a plan for them. And at the very end of that 2-hour training, one of the pharmacists in the room rose their hand and said, hey, this is great, but how do I get paid? If I spend, an hour with a patient, how do I get paid for my services? And right then, we kind of started looking around at each other, and we're like, well, there's different payment types that you can do this, but no one had a concrete answer. So that led to other questions. There was questions that like, can I do this over telehealth, over a Zoom call? What other clinical services can I provide to the patients to help them out with their healthcare? And all of a sudden, all these people in this room, it was technicians, it was students, it was pharmacists, they all started talking, and it just came to fruition of all the problems that were out there. And then all of a sudden you saw the ambulatory care pharmacists talking about ambulatory care issues. And you saw the hospital pharmacists talking about transition of care and how could they get a transition of a care service started. And it was apparent to me that everybody in all the situations had questions that they needed answered. And that group of people, we decided that we weren't going to just leave the meeting and not do anything. So we wrote everything down and we started trying to figure out how we get these questions answered. One of the things I found out that there was a national association called NASPA that helps states get laws passed, helps states with payment, lots of different things. And when I contacted them, they said that Nevada was not a part of NASPA. We were the only state out of all 49 or all 50 states that was not a part of them. And they told us if we wanted to be a part of them, that we had to do certain things. And that is how the Nevada Pharmacy Alliance started. And just from the development of it, I became the executive secretary, and now I'm highly involved in that and advocating for our profession in our state and nationally.
Awesome. I love hearing that because you hear all the time about grassroots advocacy, getting people together that are like-minded, and it shows you the power of having pharmacists together and really the power of the organization. So that is a fantastic example of grassroots advocacy. But to kick things off, what is advocacy? So advocacy, by definition, is public support for or recommendation of a particular cause or policy. And so this is you dedicating and showing your support for something not in the spirit of self-interest, but for true improvement of the cause. Advocacy itself is really empowered by individual stories or real world examples. I mean, we see it in political races. There's things we can talk about, things we can advocate for, but whenever you have someone that says, hey, this has happened to me, hey, I am a frontline pharmacist and this has been a barrier to me providing the top level patient care that I can. So it is those stories that gives advocacy its teeth to really make change. And so that's why we're always, throughout this presentation, we're really going to talk about the power of getting involved and being that person that delivers that story. And so there's a number of different ways to have advocacy. One of those is to get laws changed. And an example that Dr. Kunke shared with me that I wasn't aware of was that back in 2017, pharmacists could not order labs in the state of Nevada. And a pharmacist was concerned about this, was seeing that this was a barrier to providing excellent patient care, to being able to do that effective medication therapy management that they needed to because they didn't have all of the information. They're like, why can't I do this? I understand how, I understand what I need. Can we make this change? And they went about making a law change to now in the state of Nevada under practice agreements, pharmacists can do that. And so that is a great example of advocacy leading to change at the end of the day that helps the patient, which is the ultimate goal. Another form of advocacy is helping others, whether it be providers, whether it be the public, whether it be your mom, understanding what a pharmacist can do and what a pharmacist can do on a team. And we understand the importance of having our providers understand that, but there's nothing more powerful than having our public understand that, your family members, because they are the ones that help us to choose who our legislatures are, that affect laws. And so building that rapport, even amongst your patients, is going to go a long way. And it can help us address some of the hesitancy that people have with having pharmacists be more involved in healthcare and making more definitive decisions. And with that, I'm going to turn it over back to Dr. Kunke to tell us a little bit more about why advocacy is so important.
Yeah, I mean, you just made a point, Dr. Christensen-Grant, that hit the nail on the head. And if it's not the pharmacy professionals that are advocating for what they need, who is going to do it for them? One thing that I realized is that if I'm working in community pharmacy, I'm the expert of what's needed in community pharmacy. So we need those community pharmacists speaking up and saying what's needed, but not only that, educating lawmakers, educating the Department of Health and Human Services, educating the Board of Pharmacy what's needed and what changes can be brought about. Since I'm not working in community pharmacy anymore, a lot's changed since 2017 that I don't know about. So my question to the attendees is, what is holding you back from taking care of your patients? Are the laws stopping you? Is it something that needs to be changed legislatively? Are you getting paid for your work? So say you sat down with a patient for 30 minutes and went over their whole complete medication profile. And in there, you found out that they were having some drug interactions. You found out that some of the medications probably weren't needed or they weren't the best medications. And you're now starting to take steps to actually benefit that patient. Well, can you get paid for that? Right now, pharmacists are not able to sit down with a patient and get paid for clinical services like other providers, like nurse practitioners, physician's assistants, and doctors are. But we are the medication experts, and we should be. So this is work that we're doing on a national level and state levels. But like we keep saying, it's the pharmacists. We need the technicians, the pharmacists, the interns to come out there and help us advocate for this. So that is why it's so important. If we're not going to be doing it, who's going to be doing it for us? Nobody.
So I want to talk about this idea of what are we going to do? What are we advocating for? So we're going to talk about two things: increasing the scope of the pharmacist, the capabilities of the pharmacist, and then the other side of the coin, which is the getting paid part. So I do want to point out that these two things are not the same, even though they're often used interchangeably, or there's just assumptions made, or if anything, wishes, that if one happens, the other one automatically happens. But let's focus on increasing scope. This is what a lot of us have focused on. We want to practice at the top of our license within what our capabilities of our license are. A great example of this is collaborative practice agreements in both of our states. Prior to having the ability to have a collaborative practice agreement, there was many activities a pharmacist just couldn't participate in, or they had to get a physician to sign off on, or they were just, giving advice to the physician. And with collaborative practice agreements, now pharmacists within an agreement with the physician can do a lot of things. They can order labs, order doses, change medications. And so collaborative practice agreements are a way of increasing scope. And it was, in many states, a fantastic first step. And now we're looking at how do we go and continue to increase now within what we can do independently. And that's something that is gaining a lot of traction across the nation and amongst a lot of pharmacists. So taking to the other side of that, keeping in mind that increasing scope does not automatically mean you get paid for it, let's talk about ways in which you can be paid as a pharmacist for your services. So the easiest way is honestly cash. You know, if a patient is willing to pay and you can bill them for a service, that's quite easy. If you have a patient that you call up and you're like, hey, I'd love to have an appointment with you. I have some concerns. I think I can make some recommendations, and bring your meds in. I'd love to talk to you about it. And you say, if we do this, you know, $75 and we'll have an hour appointment. If they're willing to pay cash, that's fantastic and a lot cleaner to do. Where things get a little more complicated, and where it actually is the majority of our patients, is dealing with insurance. And so insurance is a way for pharmacists to get paid, but looking at how we do that is complex. And so looking at the national level, we have Medicare. And Medicare is one of the largest healthcare provider entities in the country for patients across the US, and it is regulated on a national level. So we're talking Congress, we're talking up on Capitol Hill in Washington, DC, in which changes would need to be made in order to feel those effects across our country. Now, looking at our individual states, our states of Utah and Nevada for our colleges, we can make changes, and those would affect like our state Medicaid programs. Those would affect private insurances like Select Health here in Utah, or Cigna, or Blue Cross Blue Shield, or United, or whatever it may be. Making those changes on the state level will then get us paid with those entities. And with those, we'll talk more about certain things that pharmacists are doing in their particular states, like addressing things like payment parities and things like that here in a second.
All right, so history of pharmacy, payment for services. The reason why we're spending so much time on payment is because in other states and in Nevada and in Utah, we see the scope of practice getting opened up, but companies and hospitals and things, other places, that now pharmacists can do these services, but if they're not going to get paid for them services, it's hard to take them off another role that they will get paid for and move them into these new roles. So that's why we want to hit so much on payment, and why states are focusing on this and pharmacists are focusing on this. So traditionally, pharmacies were paid for product. So if a patient came in for a bottle of amoxicillin, we would, take our cost and maybe add a few dollars on top of that cost to pay for the bottles and the pharmacist services and the technician services. So pharmacies were able to run very well on getting paid for the product. They were able to give counseling for free. They were able to spend time with their patients. But throughout the last, I'd say about 10, 15 years, we've seen payment for product going way down, and pharmacies aren't actually making as much per prescription as they did in the past. So then we had to start looking at, okay, pharmacists is still spending as much time with the patients, but how do we get payment for services? So let's take an example in a hospital. So hospitals noticed that pharmacists would really help when they were a part of a patient care team. So they started taking pharmacists out of the inpatient pharmacy and putting them on the floors with doctors and nurses and PAs. And now the pharmacists with their medication experts on those floors. The way that the pharmacist and the whole teams are paid for are called value-based services, or basically they're working as a team to give the patient the best care possible to get the patient out of the hospital and make sure that they don't return. So pharmacists are able to help out by making sure that they're getting the right medications and they're familiar with how to take them. So that's how pharmacists are lumped in a group. But another way that pharmacists can get paid are for individual clinical services. So I gave an example earlier. So say a pharmacist sits down and does that 30-minute consultation with the patient, and they do their assessment, they collect all the data that they need, they find some issues. So now they're going to partner with the physician, and they're going to talk about ironing these issues out. And maybe these issues that they ironed out really help the patient. And now the patient is maybe off of medications. They're not going to the hospital as much. They're not going to the doctor as much. So it's saving the whole healthcare system money. But the problem is pharmacists are not able to bill for those clinical services where they sit down for that half an hour with the patient, even though other healthcare professionals are. So that is where we're really pushing to make sure that pharmacists are getting paid for those clinical services, just like the other healthcare professions.
And so let's talk about provider status. It's a lot in the pharmacy news, it's a pharmacy buzz. So what exactly does provider status mean? And it can mean different things to different people about gaining that provider status. But if we're talking the big honcho, what really provider status means on the grandest of scale, it means becoming a provider within the Social Security Act. And that means that pharmacists would be able to participate in Part B of Medicare. They would be able to bill or get paid for those services through Medicare that fall within the state scope of practice. And what's great about this is Medicare being the national entity, like we alluded to, usually with it having such a big reach and treating so many patients, that if changes happen within Medicare, you will often see a trickle-down effect in which that will then go to the state Medicaid. It'll then also go down to the state level with the private insurances as well. So in terms of getting those changes made, whether federally or on the state level, let's go back to Dr. Kunke to talk more about how those things happen.
Yeah, so like Dr. Christensen-Grant was saying, we have federal legislation that has to happen. And the one that's being worked on a lot is the provider status under Medicare Part B. Since this is a federal law, the national organizations that are going to help lead pharmacy reform are the bigger associations, the national associations like APHA and ASHP. Those are the two biggest ones. If we are talking about state legislation, which is increasing the scope of practice in the states, or going for the payment for state Medicaid, or for the private insurances like United Healthcare or Blue Cross Blue Shield, these are usually state organizations that are going to be pushing for this type of pharmacy reform. So like the Utah Pharmacists Association, the Nevada Pharmacy Alliance, Utah Society of Health System Pharmacists, and the Nevada Society of Health System Pharmacists. Remember how I used to think that other people were going to take care of the issues here in Nevada? Well, I realized very quickly, the more I got involved, is that APHA is clearly focused nationally. ASHP is focused nationally. When I started talking to people from those organizations, they told me right up front that we can't come into Nevada and change the laws there and help you guys out because you guys are on the ground, you guys are the experts, you know what we needed. And that's, it just keeps coming back to that we need the people here in our states, here in each practice setting, to really be fighting for what they need.
So in terms of how laws get passed, just like a quick overview of how it happens and where you could plug into the system. And so I want you to realize that I'm going to talk about this as like you're an individual, but realize being a pharmacist, you have the opportunity to join those organizations where you are a more unified voice, and they go through this same process as well in terms of getting things that they want to see in terms of getting laws passed. So the first thing to do is to identify the problem. And as I kind of alluded to, as being an academician, I love pharmacy, I can advocate for pharmacy, but I'm not that frontline person. And so the issues that are identified are either told to me or I hear about them, but having someone that says this particular issue is harming my patients, this particular issue is a barrier to me providing the best care that I can, is a great starting place. And whenever you do that, you're going to identify your issue. You're going to start working with someone to develop a piece of legislation. So find a legislator that can sponsor that and help you design that policy. And then during the legislative session, as that policy is brought up and is being discussed in the session, that's where you're going to start to build support, have the legislators start to hear you out, understand more about the bill. And this is a great place where our state organizations come in and make statements saying, we as an organization support this, USHP supports this, and we can work with our partners to build even more support, saying the Utah Medical Association supports this. More recently, we just finished our legislative session here in Utah a couple months ago. We had a big House Bill 178, and our pharmacy organizations were telling us, make sure you contact your local legislator, let them know you're passionate about this. And they provided a summary so that we could make sure it aligned with what we wanted. And I sent that out to my friends and family. And I said, will you please read this and ask me any questions that you may have. And you are in support, please reach out and help us. And so that's where you're building that support. And if it's ultimately passes and becomes law, then we're looking at now we've made a change and we're looking for that new potential issue that we can address to continue to move pharmacy forward, and not just pharmacy forward, but safe patient care as well.
All right, so current payment for pharmacists nationally. We talked about this a little bit, but medications and products was one of the ways that pharmacists get paid. Part of teams is another way pharmacists get paid, but nationally laws have passed, maybe ASHP, maybe APHA, maybe another national pharmacy organization fought for these. But let's talk about things, what clinical services that pharmacists can get paid for currently. So the first one's vaccines. This is a huge thing with the COVID-19 pandemic. Luckily, we already had a lot of processes in place for pharmacists to be able to step up and help patients. The next one is medication therapy management. You do see a lot of pharmacists and pharmacies doing this inside pharmacies and helping patients. Most people don't know the next three that we are able to bill for, but we are able to actually bill for diabetes self-management services or annual wellness visits or transitions of care. These are ways, there's different, depending on what type of pharmacy setting you're in and who you're working with, there's different ways to go about that. And you have to ask those questions like, how do I do this? And how are we going to figure this out? But these are ways that pharmacists can get paid nationally.
So I want to take a look at some other examples of clinical services that are broadening the scope of pharmacy across the state, Lord help me, across the country. I do want to be clear that this is not an exhaustive list, just some examples. And more than anything, looking at other states, seeing what other states are doing is a great starting point to say, why can't I do that here? Or how did they make that happen? And it lets you find people that you can talk with and discuss to understand how they made that happen and how you could potentially make it successful in one of our states. So the first one I want to talk about is test and treat. So there's a number of states that have test and treat policies that allow pharmacists to perform CLIA waiver tests for a variety of different conditions and treat patients pending the results and if they fall within that protocol. And so Utah is one of those example states, and on this picture is those in red actually have test and treat protocols. At this time, Utah was having theirs passed, and so that's why it's a different color, but it is passed now. And so in the state of Utah, pharmacists can diagnose or test patients and then treat them in the community for things like strep throat, cold sores, uncomplicated urinary tract infections. They could assist with self-administered contraception, yeast infection, long-acting injectable medications, and those are just some examples. Other states can do things like hepatitis screenings. They can do things like animal bite prophylaxis or burn management, and those are just some examples of things that other states pharmacists can do. And then looking next at getting paid for minutes spent with patients. And so there's states like Washington and Tennessee where pharmacists can get paid for their time spent with patients, whether it be an NTM visit or something like that. And this really rose around from this idea that there were other healthcare providers like physician assistants, nurse practitioners that had their own MPI number. They could bill for these services. And these are things that pharmacists can do as well. And so this is this idea of payment parity. And so these states have been trying to pass things in favor of payment parity for pharmacists so that they too can get billed if they can perform the services that someone else can get billed for. Washington and Tennessee are two states taking a lead on that. Some states like Iowa are working with employers. And so they found ways to maybe not go directly to an insurance company or Medicaid. Instead, they go directly to an employer. They say, you know, if we can get involved, we can make your employees healthier. We can have them miss less time at work. We can make them maybe some weight loss management, smoking cessation, wellness visits, come in and get flu vaccines. And so working directly with them to get paid through the employer for these services that are making their patients healthier, like programs we have at Roseman, like our wellness program, or things you might have with your company focused on your personal health as an employee. And then there are states like Ohio that have worked directly with their state Medicaid programs in a similar fashion. They've said, look, when we have pharmacists involved in patients' care, we can produce outcomes that make patients healthier, so they're spending less dollars of yours, of the Medicaid program. So having a pharmacist involved, it has an improved A1C, or management of their diabetes. They have better blood pressure control. I can reduce the number of medications they're having to take. So things like that appeal to the Medicaid service in Ohio, and they form that program.
One thing I wanted to add on to that slide is that I was actually on a call with the executive CEO of the Washington Pharmacists Association, and she mentioned that they have over 300 pharmacists working in clinics now that they have passed that payment parity. Compared to Nevada, we have only identified about 20 pharmacists working inside clinics in the state of Nevada. So when laws like that get passed, now pharmacists can go out there and find new jobs and show their skills and help those patients and help those teams. So that's just one thing, one example of when you expand the scope of practice and payment is with it, you can see that pharmacists are now able to help their patients. So what are states throughout the country working on, like right now? So it says full prescribing authority, but this is a very, very neat thing that happened in Idaho. And this has been a couple of years now. They're not working on it, but they're working on putting it into action. One thing Idaho did is that they said that pharmacists can do whatever they've learned in school, and they basically is under their scope of practice. So now we're in Nevada or Utah, a pharmacist would have to collaborate with a prescriber, a nurse practitioner, or a PA, and create a protocol on what they could do. Idaho no longer has that. They have opened up the full prescribing authority for pharmacists as long as pharmacists are taught that. Payment parity, we were talking about how Washington and Tennessee already had that. Well, Ohio, Texas, West Virginia, and Maine are now also in legislative session to get payment parity for pharmacists. PBM reform, PBMs, prescription benefit managers, are middlemen between insurance companies and pharmacies that set prices for medications. And there's been a lot of studies out there saying that they, instead of them lowering the cost of medications, that they're actually taking money from the insurance companies, from the state Medicaid programs, from the pharmacies, and they're keeping it for themselves for profit. So almost every state right now has either passed PBM reform or they're actually working on that. And that is important because remember, the payment for the products that we are selling has gone down, and the PBMs, many people blame them for that. And then partial prescribing authority. In Nevada, we have two different bills that are in the Senate right now. The first one is a standing medical order, and what a standing medical order does is that the chief medical officer will write this order, and that will allow all pharmacists to prescribe certain types of medications. So what this standing medical order is if it passes, our chief medical officer will write this protocol and allow pharmacists to prescribe hormonal contraceptives. We also have another bill in the Senate right now, and it's actually a protocol. And what a protocol does is it's going to allow the State Board of Pharmacy to write this protocol, and it's a stepwise thing of what pharmacists will have to do. And if that passes, if it passes, then once the State Board of Pharmacy puts that protocol in place, then pharmacists themselves will be able to prescribe certain types of medications. And this is, in this case, it's HIV medications to prevent HIV. So lots of things going on. I keep hearing that over the last 2 years, more movement has happened in the practice of pharmacy than I've seen in decades. So this is really exciting stuff, and we got to make sure that our states keep up with this.
So to keep you excited about what's happening and to keep you motivated about what's going on in our states, we're going to highlight next what is going on in our particular states. So in terms of scope within the state of pharmacy, and in terms of vaccines, which is a big topic right now, we are more on the progressive side. For a number of years now, we've had where technicians can assist in vaccines. And so we do tend to be on the more progressive side there. Our collaborative practice agreements here in the state of Utah tend to have a very wide scope. And if there is a practice that you want to put into place and you can partner with a current prescriber, you can almost do anything. But CPAs are often underutilized within the state of pharmacy, within the state of Utah, often due to concerns about how do I get paid for this and things like that. So we do have a pretty wide scope, but it is often underutilized. A quick summary of our 2021 legislative session, which ended back in February, I believe. A big bill was passed, House Bill 178. This bill recognizes pharmacists as a prescriber, starting in January 1 of 2022, granting us the ability to prescribe a number of medications, starting off with medications focused on public health, but the intent is that this would be broadened by committee in the future. So this is just the start, and the motto is hopefully this can mirror a lot of what Idaho has done. Now, as awesome as that is, and a huge victory and fireworks and everything for just how great that was, it did not address the payment part of it. So even though we will be recognized as prescribers, we are not currently recognized as a provider under our state Medicaid, and so the payment has not followed. So that's where we currently stand. We're en route to where we want to be, and now we've got future steps to make.
All right, so where does Nevada stand? So just like Utah, Nevada is very progressive in vaccines. There was a lot of states, normally back east, that did not allow pharmacists to give vaccines at all, but pharmacists have been able to give vaccines for quite some time. And right now there is an emergency act where the Board of Pharmacy passed or didn't pass, wrote up, and the governor signed, where pharmacy technicians can also give vaccines. Right now, Nevada's collaborative practice agreement is very strict. What that means is that it has to be done by referral. So a prescriber would have to refer that patient to the actual pharmacist to do something. Where other states' collaborative practice agreements like Utah, they're more social, the collaborative practice agreements. So say a patient came up to a pharmacy and they had a sore throat, and the pharmacist had a collaborative practice agreement in place for treating for strep throat. They can give a rapid strep throat test right there. If it tests positive, then the pharmacist could prescribe that medication and collect a fee for that. So that is what's being worked on right now in the 2021 legislature, is opening that up to be more of a population-based collaborative practice agreement. We already talked about the protocol for the PEP and PrEP and the prescribing of hormonal contraceptives. So we're excited to watch that go through the actual, right now, they are in the Senate, and a couple of them passed the Senate and they're going over to the Assembly. But we would really love if you contacted the legislature and told them that you were in support of that. It's very important for the profession. Also, one of our bills that's going through right now, the PEP and PrEP bill, it would recognize pharmacists as a provider type under Nevada Medicaid. So this is an important step, because this would be the first insurance in the state for pharmacists to be recognized under 4 clinical services. So again, lots of fun things happening, and we just want to keep moving forward. And once this session's over, we got to start planning for the next session and what the profession needs for our 2023 session.
So how do you get involved is the next thing we want to talk about. So one thing to do is to keep current with what is currently affecting pharmacy, healthcare in your particular location. And so whenever the legislative session is going on, follow along on the state legislature website, follow those bills, figure out what things matter to you. And listening to those, even the things that are outside of pharmacy but affect healthcare, will help you become more educated in the issues affecting your state and help you think of how my expertise, how is me as a pharmacist weave into this, and do I or do I not, and can I assist if need be? One thing you can look at is your legislators. Find legislators who support issues that advance the practice of pharmacy and make it easier or even better for you to deliver patient care. And there's a number of ways to do that. So like, for instance, let me click real quick. Like the Utah State Legislature has the ability right on its front page where you can find my legislators. And then if you look at something like nationally, like APHA, the American Pharmacists Association, they also have the ability for you to look up who your federal and state legislators are, just in case you don't know. And then you can start reading up on what their policies are, what things have they supported in the past. And if you know of a recent healthcare or pharmacy related bill, you can see where they stood on it and what they voted. And this will give you some insight into voting in the future. Another great recommendation is to attend a Board of Pharmacy public meeting. And one thing to keep in mind is that the Board of Pharmacy has a very specific job. Their job is for patient safety. And so they're not necessarily there for pharmacy advocacy. You know, their agenda or their mission really isn't to advocate for the pharmacy profession. But by attending the Board of Pharmacy meetings, you can learn about the things that are affecting your colleagues across the state. You can learn about things that are concern of patient care. You're learning about things that may generate ideas of laws that may need to be changed. So I do highly encourage, if you are available or if you work in a pharmacy where you have two other pharmacy partners that you work with, to maybe take turns going to the Board of Pharmacy meeting and reporting back on what's happening within your state. I think that's tremendous. And on both of our state boards of pharmacy, it's pretty easy that here in Utah, if you go to the DOPL website, you can go and find the board information, and they have the upcoming meetings listed here. If you click, you'll be able to find their virtual attendance right now. They used to be in person, but now they are held virtually. And the same for the Nevada Board of Pharmacy. If you go to their website, you can also here view meeting dates, times, previous agendas, minutes, along with Zoom links to connect to their meetings as well. So these are ways that you can get involved and at least make connections with your colleagues that may be facing similar things to you. Next, you could participate in your annual legislative days within your state. I would happily connect anyone that has a passion for getting involved with this. I will say historically in Utah, this has been a very student-centric type event. And this past year, we had speakers from all over the state talking about advocating for the profession by saying, this is what I do in my profession. These are the advances in pharmacy practice I have made. These are the innovative things that I am doing. And moving forward, we want to do more of that. We want to highlight not only to the legislators, but also to the public the things that pharmacists can do. You can also join your local and state organization. Here I have links for all of our local and state organizations, including UPHA, USHP, the Nevada Pharmacy Alliance, and NVSHP. And by clicking on these links, you can go to their websites and see, how do I join? You'll see the committees they have. I highly encourage you to get involved with a committee. For instance, I'll speak about USHP because I'm involved with USHP. You can get involved with advocacy. You can get involved in programming and inviting speakers to come in for CE or the annual meeting. So it's a great place to meet people that are like-minded and then advocate as a unit for the profession. You could also sign up for legislative alerts and electronic mailing lists. You can educate the public on the role of the pharmacist in healthcare. And this is something you can do every day. As you have those patients that come to your pharmacy, make sure it's known that whenever you're giving them a service or the things that you would like to be able to do, and say, you know what, it would really mean a lot. You just told me you really value this. If you went next time you could, let your legislator know that you value what your pharmacist can do for you and you want them to support the roles of you as a pharmacist. That is tremendous, because as a pharmacy profession, we are great in number. As a public, we are greater in number, and that would be tremendous. You could host a legislative visit at your site, at your local pharmacy. Have the legislators come in, highlight what you're doing for patients. Are you hosting a clinic for the day? Have them come in and see how you as a pharmacist are directly helping the community. You could seek appointed positions in your state or county's health department. You could also become a pharmacy preceptor to help prepare future pharmacists, to help them understand their roles and to really give them the energy to do great things upon the time they graduate.
All right, that was a great list of ways to get involved and advocate for the profession. There are some other resources out there that we did want to mention. The first one is Facebook. There are some Facebook groups out there. One of them is called Pharmacists Take Action. The other one's called Pharmacists for National Provider Status. The state and national associations usually have Facebook and LinkedIn accounts. But one thing here is that if you go on to these type of websites or podcasts, make sure that you realize it's just to gather information. You can comment all you want. You could fight people on there about different topics, but the thing is that's not advocating for your profession. That's participating in social media, and it's not educating the Department of Health and Human Services or your senators or your lobbyists or what is needed. So make sure that you are doing the right things, like on Dr. Christensen-Grant's list. Some other podcasts, the Pharmacy Podcast Network has a podcast called Transforming a Nation. And then you have your magazines like the Journal of the American Pharmacists Association, Pharmacy Today, American Journal for Health System Pharmacy. These, I flip through them all the time just to make sure that I'm catching all the advocacy articles that are in there now. And I'd say about one article an issue is about advocacy. So I read it and I save it in my files in case this topic comes up again. But like I said, just make sure this is not advocating, this is gaining knowledge and seeing what else is going on.
Here, I will second that. I think it's tremendous to gain knowledge and learn, but you want to look at joining your organizations or truly advocating to make those changes. So let's kind of start wrapping things up and understanding globally. Well, we talked about all of this and how great it is, but why would certain groups be against expanding the pharmacy practice? So there are other health professions that maybe are not as much in favor of this. There's concerns of, are you stepping on my toes? Or I'm worried that you are infringing on my practice, or I don't quite understand what a PharmD does, so I have concerns. And so as a part of your job in advocating, you could be doing that within your practice, working with them to say, look, this is what I can and can't do, or what are you too busy to do, or what do you feel like I could help you with? And start, rather than taking pieces of what others feel like they own, say, well, how can I come in and assist and fill gaps that are currently there? Insurance companies, again, they're not going to be inclined to pay for something up front. They need to know that they're getting some benefit for it. So whenever we come in and say, hey, we want you to pay us for this, you should pay us for these services, they're not going to be inclined to do so unless we prove that at the end there's going to be a benefit for them. There are political ramifications to this as well. Whenever bills are up for vote and in the process of becoming a law, there is a part of, if there is a powerful organization lobbying against what you're saying, that'll come into play. And so getting their buy-in is helpful as well. And that's where our unified pharmacy organizations within the state can help us do that, as they bridge those relationships. There's also people that don't understand how pharmacists are trained. Remember, it's not that long ago that we switched over from the bachelor's in pharmacy to the doctor of pharmacy and changed the way we educate pharmacists. So it's not unheard of that people just don't understand what a pharmacist does. And Ken brought this up beautifully, that our pharmacy profession has been changing rapidly recently. And so people, again, don't understand the things that we can do. And last, this one, honestly, if someone's scared for patient safety and holding me accountable to say, wait, this is how I can actually help. These are the things I'm going to do to not harm patients. So this last one, I get and I understand, and I really appreciate these people that are causing us to be accountable for these things we're advocating for, but it does require education on how we can address these concerns as well.
So one thing that I was confused about before I got involved is, how do pharmacy associations work? I thought if I paid some money that everybody was going to do things for me. And while the money is nice, it actually is the actual members that have to do the work. So every association is governed by bylaws. So if they're not posted on the websites, you could probably request them. And those are going to be their mission statements, what they're going to be working on and what the board of directors are going to be going towards. So always, if you're interested in an association, go to their website, look at it, ask for bylaws if you need to. But the bylaws are going to state who can join and who can be on the board of directors. Most of the pharmacy associations, the state pharmacy associations that we're talking about, they're set up so it's going to be pharmacists and technicians and retired pharmacists and people that are actually going to advocate for our profession. It's a they're member-driven associations. So basically, they need to take what the members are asking them to do and work towards that. So if they have a group of people that want to work on community pharmacy issues, they'll have them working on that. And the hospital issues, they'll have them working on that. But the board of directors are going to make a vision for the next year and what they're going to work on. And the officers are going to create the goals based on the feedback of members. But associations don't work without member involvement. It's so important to make sure that you're involved.
And so we want to finish things up by saying, why is it important for us to work together? So we've really highlighted this throughout the presentation because it's something that we really feel is important, that at the end of the day, who is going to speak up for you and get these things changed? As much as I want it to be me, it can't always be me. I don't understand the things that are affecting maybe those that work in a compounding pharmacy or those that work in nuclear pharmacy or those that work in long-term care. You know, it's going to be those of you out in the community facing these issues. It's not going to be the pharmacists advocating for change on the national level. It's not going to be our national organizations. They can help, but at the end of the day, we need to focus on what's happening within our states. And it's also not going to be Idaho or Washington or Tennessee. It's going to be our home states. And then who's going to make those changes? Who's going to take the lead in pharmacy associations? I know at times it can be scary to join a state level organization, but realize the pharmacists that are a part of that organization, they are just like you. They are a practicing pharmacist that's just decided, I want to be a part of this. And so if there's any intimidation, and I will easily say that when I first came to Utah, I was nervous about joining one of these organizations because I was intimidated. But once I joined, I realized I was surrounded by people just like me that really just want to help. And I found new friends, new colleagues that I can work together on these things. And so I really encourage you to get involved. The only people that can do this is you. So it really is up to you, and we've got to do this together. And with that, we will take it over to the Q&A session.
Wonderful. Thank you both. That was fantastic. Such great information. It is time for the Q&A. I will remind you, we have a few questions. Please don't message me directly. You can put your questions in the Q&A so everyone can see them. But that said, let me jump to those questions. The first one is, we touched on this a little bit, how do pharmacists find more time to do clinical services, and will this lead to more jobs?
That is a good question, and that's especially with the pandemic. It has shown that pharmacists were tasked with a lot of things to do during the day, and now that the pandemic was here and they have to take care of patients through giving flu shots and other things, now it's even more of a hurdle. The one thing that I gotta say is that we know that the payment for dispensing is going down. And so we know that we need to have laws that allow us to do clinical services. So say that a community pharmacy, they are only focused on dispensing products. What happens if we're like Washington, where we open up 300 jobs where pharmacists can transition into a more clinical based job and take care of the patients more? What happens if we give technicians in those actually dispensing roles a little more leeway to maybe check refills or do something that gives the pharmacist more ability to do their clinical services or practice at the top of their license? So it is going to create more jobs, the more things that we're going to be able to do. But it's one of those things. It's a balancing act right now, opening up that scope so pharmacists aren't tasked too much, and making sure that the pharmacists are practicing at the top of their license, and technicians are actually practicing at the top of their license also.
Good points.
I would say that I think something that would be really great to think about is looking at your resources in your colleagues. So we've talked a lot about getting involved in organizations, but I think in terms of meeting with colleagues, whether it be through the Roseman Alumni Association, or whether it be joining or going to a meeting and meeting someone, getting people on your team that can help you. So if you work in a hospital, try to build rapport amongst your team and realize you're not alone. I've seen so many pharmacists that, they feel like they've got to do it themselves. And it's like, if there is a project that can streamline the way you work, get a colleague to help you and tackle it together. As a part of our Roseman model, we are team-based, and then we graduate and we feel so isolated within our walls of our pharmacy. But realize, just because on the day-to-day you're maybe working within your walls, but we are a network of pharmacists that are working together. And so reach out to your colleagues, reach out to your friends, and start working together on projects that can streamline your workflow or advocate for improved work.
Wonderful, wonderful, thank you. All right, second question. What is the difference between standing orders, protocols, collaborative practice agreements, and full prescribing authority?
All right, that's a good one. We touched on it a little bit, and we've mentioned, I think, all the different things, but if we put them all together in order, I think that would be the best way. So a collaborative practice agreement is a pharmacist working with a prescriber. So a doc, like a DO, an MD, a PA, or an advanced nurse practitioner. And you guys work together to decide what the pharmacist is going to be able to do. So if a pharmacist say a doctor prescribes a cholesterol medication and the patient's cholesterol goes down to normal levels, and it actually goes lower than normal levels, the pharmacist can automatically lower that dose of the medication for the patient without going to the actual prescriber and saying, hey, can I do this? So it's set things that the pharmacist can do under with the actual agreement with that prescriber. Full prescribing is the pharmacist is now opened up to do that without getting the actual agreement with the prescriber. So you are full practice. The other one was a protocol and a standing order. So a standing order is when a doctor, usually the chief medical officer in the state, writes the order and he's actually the prescriber, but pharmacists can dispense from that order. Where a protocol, it's a list of things a pharmacist would have to do to be able to prescribe.
Gotcha. All right, wonderful. Thank you. That was clear. All right, I have one more question, and then again we'll open it up to see if anyone else has any others. What if I have volunteered to help an association, but they haven't contacted me? Okay. What's the next step?
Being a part of an organization currently, like I've said, they are just like us, and so at times things can get lost. So if you ever reach out and they haven't had a chance to contact you back, feel free to reach out again. Feel free to maybe reach out to the committee chair and say, hey, I was interested. See if you know someone that sits on one of the committees. If you contact me and right now you want to join programming committee or you want to join something, I'll connect you with someone and I'll give you a meeting time and say they would absolutely love to have you. So I would say for the state organizations, just reach out again, because I know both of our state organizations here in Utah would absolutely love to have you.
Yep, and throughout the years, the leadership does change, and you may have contacted them right at the end of someone's term. Also, maybe what you were asking them to do just wasn't a priority at the time, which isn't a great reason to not for them not to get back to you. But the thing is that try and try again, please. If you want to get involved, reach back out.
Perfect. It could have been the day they got 500 other emails.
Exactly. They might have hit delete on accident and it just went into nowhere.
Exactly, exactly. All right, well, we'll wait another second to see if we have any other questions coming in. And while we are, I will just remind everyone that you are fortunate, you will go ahead and get a copy of a PDF of the slides, thanks to Dr. Kunke and Dr. Christensen-Grant. And we will send those out to you next week, along with a video link to the recording of this presentation, which was fantastic. Let's see if we have. All right, I think we don't have any additional questions. So with that, I will say thank you so much to our presenters. Thank you to all of our participants. And I will look forward to seeing everyone next month for our May Roadrunner Resource Series presentation. I'm excited to say it's going to be Dr. Kaylin Bowman, who is not only a Roseman alumna, but she is also the current pharmacist with the Roseman Medical Group. So we will look forward to hearing from her next month. Watch for more information. That's it. Thank you, everyone. Have a great night. Bye-bye.